Namaskar, hello, and welcome to the day two of the 2 day mega virtual IndiGlobal Healthcare Summit that engages powerful minds in the healthcare sector, empowering transformation for a healthier world. Disruption and the way ahead is the theme of this 2 day mega virtual summit that has seen policymakers, leaders from the healthcare sectors, innovators, and experts participating in sessions including powerful panel discussions, leader talks, awards and recognition, and also strategic workshop. The day one was amazing with an inaugural session on the evolving landscape of Indian healthcare system and the way ahead. And it has seen the participation from the Government of India, Ministry of Health and Family Welfare, National Health Authority, the Executive Director, Dr. Sudha Chandrasekhar, joined us from Delhi. And also, we had representation from states like Kerala, Dr. Ratan Kelkar, Mission Director, National Health Mission, who's also the Executive Director, the State Health Agency, Government of Kerala, and also Government of Telangana, Dr. Srimati Harichandana Dasari, and other leaders joined us. And throughout the day, there were many powerful panel discussion on heart health, impact of heart health in the COVID-19 era, and the digital transformation in healthcare system, and also the evolving landscape in the diagnostic sector. These were very important sessions that were discussed on, and we had esteemed speakers joining us from across the country, and even today we are lined up with some very interesting panel discussions and leader talks. Just to brief you all, right now we are being broadcasted through a 3D virtual platform where over hundreds of delegates from across the country have registered and are watching us live. At the same time, we are being live streamed in several other social platforms, including IndiGlobal TV, that is YouTube channel, and also Facebook and also LinkedIn. So I welcome all the delegates who have joined us yesterday and also today. So today's opening session is going to be powerful with leaders with decades of experience joining us as our esteemed speaker. And today's opening session would be focusing on building a resilient healthcare ecosystem. While our Indian healthcare system has risen up to the occasion during the COVID-19 era, which has seen over three waves, we were caught unprepared. But it also has shown us how the digital technology in healthcare played a very important role and how we got to be prepared in future. For that, we need to have and build a resilient healthcare ecosystem. We would also be touching upon effective management of infectious and non-infectious diseases, which also needs a robust infrastructure, both digital and non-digital. And during the COVID-19 era, we also faced the drug uh, scarcity. It was maybe due to the market. We would also be touching upon the drug availability and its market, redefining emergency healthcare system. These are the topic we would be touching upon in the opening session. And to do the honors, we have healthcare leaders who have decades of experience. The first speaker I would like to call upon on the our virtual stage is a person with over close to 4 decades of experience. He is a cardiothoracic surgeon and also the founder and managing director of Krishna Institute of Medical Science Hospital in Hyderabad, Telangana. Please join me in welcoming Dr. B. Bhaskar Rao, Managing Director, KIMS Hospital. Thank you very much, sir, for joining us. We are also joined by yet another leader in the healthcare sector. She's also the president of Federation of Obstetric and Gynecological Study Society of India. We would be hearing her. So please join me in welcoming Dr. Shanda Kumari, President of Federation of Obstetric and Gynecological Societies of India. A warm welcome, ma'am. Thanks for joining us. We would also be joined by a well-known name in the healthcare sector. He's quite popular even on the digital media. He's very interactive. Please join me in welcoming Professor Dr. Amitabh Banerjee, epidemiologist, Dr. D.Y. Patil Medical College, Pune, Maharashtra. A warm welcome, sir, for joining us.
Thank you this opportunity. Thank you.
So we have speakers joining us from Hyderabad, Delhi, and Mumbai, and delegates from across the country. So without further ado, I would like to call upon our first speaker, who would be delivering upon building a resilient healthcare ecosystem. So I would request Dr. Bhaskar Rao sir to deliver his address for this opening session. Over to you, sir.
Yeah. Good morning, everybody. Let me thank the IndiGlobal first to give me this opportunity to present my views. So it gives me a distinct pleasure to address this distinguished gathering of healthcare stakeholders and people from various walks of life. The most predominant sector for the nation or the world is healthcare sector. If the health of a people is not in good state, the economy, industry, business, and everything takes a backseat, as is shown by the recent pandemic. Anything and everything is possible only when the health is good. Thus, the importance of the health sector need not be overemphasized. There are various stakeholders in healthcare spectrum, broadly comprising of healthcare providers, that is in the hospitals, diagnostic centers, pharmacies, and everything. And similarly, the public, and any day the public will become patients, so patients are the main focus. The third important is the healthcare workers, that is the doctors and the medical fraternity and paramedical staff. And finally, the government is also plays a very important role to provide a universal healthcare. Let us examine the role of these vital stakeholders in making the healthcare industry more vibrant, widespread, and accessible and closer to communities. There is a great need for public-private partnership in the healthcare sector. The health needs and aspirations of the vast population cannot be met by government alone nor by the private sector. A cohesive joint approach is needed where both government and private players have to walk hand in hand. During the pandemic, the distinction between the government and private sector thinned down and both complemented and supplemented each other, and the results were astounding. The private sector played a dynamic role in delivering the government with all the resources it required, including testing, providing isolation beds and wards for treatment, providing medical personnel of doctors, nurses, and other staff, as well as home health care. The challenges of healthcare system: we have the second highest population in the world, thus puts a strain on the healthcare resources, and the governments, despite their best intentions, may not be able to provide as much funds as required. Are we able to reach all the needy? Are good medical services are available in every part of the country? Sadly, the answer is no. There is a vast section of rural population who do not have access to proper medical facilities. The responsibility rests both on government and private sector to take the healthcare industry forward with a great speed of and focus to provide each and every person in the public to give as a universal, affordable, quality healthcare. Though India has an extensive healthcare system, there exist significant quality discrepancies between rural and urban areas and between public and private healthcare providers. A realistic and a resourceful public-private partnership will benefit all sections and also reduce the burden on government. We have the resources available, but we have to put them to effective use of optimizing the benefits by innovative and out-of-box thinking and strategies. A think tank of public and private sector is to be nurtured, allowing free flow of thinking to evolve ways and means on a continuous basis to put healthcare on a faster trajectory involving all the stakeholders. There are many government schemes to extend health benefits to economically weaker sections of the society, but still we may not be able to cover all the public in the rural and as well as the urban areas. Current healthcare issues in India, the biggest ban for our healthcare sector is lack of infrastructure, like gross insufficiency of hospital beds, depth of doctors in general, and specialists in particular. We need more hospitals and more doctors, and also the more paramedical staff. The government has to incentivize setting up of new hospitals. More and more clinics are to be encouraged to deal with day-to-day diseases. The concept of family doctor is to be reinforced with vehemency. By revitalizing the concept of family doctors, the expenditure would become economical and many issues can get addressed without running around corporate hospitals. The government expenditure on healthcare, which is about 3% of GDP, is to be scaled up. India has one of the lowest allocations to health compared to other countries in the world as a percentage of GDP. Such low investment in health results in high out-of-pocket expenditure, which in India is among highest in the world. This situation is driving millions of families into debt trap and further poverty. As mentioned earlier, an effective public-private partnership system will be of great value in addressing the health needs, as it may not be outright possible for the government to allocate funds on much larger scale due to various other priorities. How health system is resilience. Prevention and effective cure requires a strong primary health care and a public health system, skilled workforce, and empowerment of people to take charge of their own health. We need to focus our attention as well as investment on these things. There is a need for increased national and global commitment to make countries better equipped to face all kinds of public health threats. This involves public awareness program to improve, protect and restore the health of people. Develop healthcare systems of delivery at the doorstep that is closer to communities. The third one is to improve the strengthen the emergency risk management systems. An integrated approach engaging the whole society in the common goal of providing health for all. As we mentioned, the digital infrastructure today is the era of digital. Another important aspect is digital infrastructure that will standardize the whole system as well as enforce interoperability that will reduce the cost and financial burden on patients, facilitates quick distribution and application of knowledge and awareness. This includes electronic health records, that is EHRS, the personal health records, PHRS, telehealth, health information portals, electronic monitoring devices, and mobile health applications. Also in play are collection of health information such as biobanks and health information databases maintained by large health systems. Private insurance and regulatory agencies, all these enhance the capacity of clinical care, patient education, self-management, and cost monitoring. Laudable and noble are these objectives, however, the implementation is much slower. Recent pandemic also distracted the attention and drained the resources. India has about 500 million internet users. That being the case, scope of digital platform for better addressing of health issues and for promoting universal healthcare is indeed huge. The blending of digital approach to the healthcare sector will result in improved accessibility, affordability, and quality. Such health systems synchronizes well with the idea of an all-in-all digital nation supported by the missions like Ayushman Bharat and Make in India. The concept of telemedicine proved to be boom during COVID-19 as good number of patients availed this facility at the comfort and isolation of their homes. Going further, it will enable specialized medical consultancy services across the country and to some extent mitigate the issues of doctors shortage as well. The increase in hospital costs and affordability, if we talk about what is the reasons for it, there is a clamor that hospital costs have increased. It is true that the cost of medical treatment has gone up. It may look paradoxical, but in a way, patients are also responsible for this sorry state of affairs. Nowadays, patients lack patience. Many come with a predetermined notions and not with an open mind. They are not giving time to doctors to deliberate and diagnose. They no longer trust the physician's natural instincts. They insist on overnight miracles. Doctors are not allowed to use their clinical knowledge. Patients come with off knowledge, spurred by internet or advice of friends or relatives, and insist upon undergoing a variety of investigations that may not be required. In that case, doctors are not left with much choice. The doctors also give in so as to safeguard their interests in the event of any litigations at a later date. So all tests are done to rule out any possibility, even if the possibility is minimal. Second thing is frequent investigations cost money, but may not reveal anything. Investigation day after day will not reveal anything new unless a reasonable time gap is given. Another important issue of concern is self-medication, which is caused by knowledge obtained by browsing, suggestions from friends and relatives, advice from local pharmacists. They start using medicines on their own and land in trouble. For example, all coughs are not same. Because somebody was prescribed a cough syrup, it does not mean that it is universal medicine for all coughs. Sometimes it may be a symptom of cancer or a tuberculosis. By using medicines on one's own, one may be masking the disease that is lurking inside. In most cases, early diagnosis of serious disorders, diseases like cancer, can make quantitative and qualitative difference to life. Supposing breast cancer is detected early, the patient can be cured and have a long and normal life, but if it is diagnosed late, it impairs the quality and span of life besides costing the purse heavily. So, if the patient do not indulge in self-medication and see the doctors early, it makes a great difference in terms of health and money. The treatment is obviously more expensive at a later stage. The patient should be aware that the doctor is more knowledgeable than him and the treatment is to be systematic and not symptomatic. Thus, it is necessary that the patient should not assume the role of a doctor but follow doctor's advice. In some cases, there are long-suffering patients who are in near terminal condition with no scope for recovery. There is apparently no use in continuing the medical treatment. In such case, out of emotional reasons, the relatives insist for continuation of treatment, though it is pointless. It only adds to the expenditure. There are some organizations that admit such patients where no further medication is given with no cost. Those options are to be explored rather than insisting upon continued treatment that only leaves a big hole in the pocket. A rational decision based upon doctors' valued opinion is required in such circumstances. If we create a concept of family doctors, we see patients running to corporate hospitals for every small thing. They should consult the family physician first before rushing to the corporate hospitals and run investigations one after the other. In many cases, the visit to family doctors will cure the patients as the doctor is well aware of patient's constitution and background. Today, many small things for fever or an appendix, they are running to the corporate hospitals. The cost is increasing very high. This shows how patients themselves are spending more and more where it is not warranted. So the golden rules for patients are: first, trust your doctor. He is a professional who knows better, therefore don't pressurize him. Second, don't insist on investigation on your own, follow doctor's advice. Third, don't indulge in self-medication. Fourth, visit the doctor in early stages of symptoms instead of waiting till it is late. Fifth, consult family doctor first. So, what does the future hold? Non-communicable diseases are now the leading cause of death in the country. Four diseases, mainly heart disease, cancer, diabetes, and chronic pulmonary disease, contribute the majority of deaths, and they share four common risk factors, namely tobacco use, harmful use of alcohol, unhealthy diet, and lack of physical activities. All these four risk factors are in the hands of the each individual. Whatever the government and other players may do, ultimately the individual has to take care of one's health by being conscious of cleanliness, hygiene, and sanitation. One must have a sense of health discipline, but adherence to health norms and have a periodical health checkups and follow up. The social awareness plays a dominant role in promoting the effective healthcare system. No amount of government effort can substitute the social awareness and social responsibility at an individual level. Therefore, I would say that true healthcare reforms cannot happen in World Health Organization or National Health Organization. It has to happen in our own kitchen, in our homes, in our community. And the same important thing is training of the medical, as I mentioned, the medical and non-medical, paramedical people. Today, there is a lack of number of seats as well as the training programs. So we need to address in a form of public-private partnership where there are many patients are available in the government institutions and lesser patients are available in the private medical colleges. So if we can able to approach in a public-private partnership, even though 50% of the students are taking training in the private medical colleges, if they join together so that the good education can be provided for the doctors and as well as the paramedical staff, that will also influence and increase the quality of healthcare to each and everybody. And the other important thing, as I mentioned, to the important stakeholders, the government. Government should be able to focus mainly on the governance about like the audits, clinical audits, then the infant mortality rates, and as well as the morbidity and mortality rates. All these put systems and policies, everything in a uniform throughout the nation. That way, the government can also have a good control to providing a quality and affordable health care. So these are the four stakeholders I have been explained thoroughly. The epidemiology, I think our Dr. Anubhav is there. He is going to talk about it. I didn't touch on that. Before I conclude, I would say that there is an imperative need for more and more seminars and webinars like this, as it widens the doors of a cross communication, facilitates flow of information, and stimulates creativity. I find that doctors in general are less active in this area as they remain focused on their work and research. So is the case with scientists who are mostly secluded and do not prefer public platforms. The trend is slowly changing and more professionals are participating in these activities. At our hospital, I keep exhorting my team members to actively take part in the academic fora so that a wide range of persons at multiple levels can derive the benefit of your expertise. Likewise, we also can get enriched by others' experiences. I am happy to take part in this webinar and I am sure the deliberations will have fruitful impact. I wish you all success. Thank you very much for giving me this opportunity.
Thank you very much, Dr. Bhaskar Rao, for we had a comprehensive and a holistic perspective that you have put forward, also touching upon the challenges and also the preconceived mindset of the patients at the same time, the challenges that hospitals are facing. Thank you very much. It will be, I'm sure, the audience out there and are getting a lot of knowledge and it is we would also be documenting this in the form of a conference report which will be presented to all the stakeholders both in hospitals both in the government and ministry of health. With this we will be moving on to our next leader in the healthcare sector. Please join me in welcoming Dr. Shanda Kumari. President for Foxy. Ma'am, over to you. We would like to have your initial remarks and for building a resilient healthcare ecosystem. Over to you, ma'am. If you can unmute the mic, please, ma'am. Yeah.
Good morning, everyone. It's indeed a pleasure to be here with all of you, and I bring greetings from FOXY, the Federation of Obstetrics and Gynecological Societies of India, a 38,000 strong body of OB-GYNs, and greetings from FIGO as the treasurer of FIGO, the International Organization of Gynecology and Obstetrics, which we cover about 132 countries. Dr. Bhaskar Rao has so very clearly discussed and stated so many issues which are involved in a healthcare system. As a leader in the healthcare facility, as being an MD of an huge corporate sector and a medical college, he absolutely put the most important issues which are at stake. What I should congratulate all of you is trying to bring out this dialogue where we need to connect with the people and all the stakeholders. Now, why is it that we need to talk about healthcare and healthcare systems? What is it that we are looking at? Friends, yes, COVID has shown us that the world can be put to stake at the very small incidence of an infection. The microbe can rule the world. That's what we have realized. And what is it that has taught us? We have realized as gynecologists, we take care of women's health. And as we go, we are the global voice of women's health. So we strongly believe that strong women are so very important for the health and vitality of the family and the society. So, what is it that you can make to have a very resilient healthcare system? You need to have strong women, empower them socially, economically, politically, and legally, and make them confident so that they can live with self respect and dignity. And in any given opportunity, they can rise to see that the best comes out. Now, where is it that all these factors are intersecting? What is it that we have seen during the COVID pandemic? We have seen that there is an intersection between gender equality, strong women, and sustainable future. Now, if you're talking about the SDG goals 2030, we had missed the bus for the MDG goals, and global leaders got together thinking like maybe we need to look at the health of everyone and we need to look at SDG 2030. We thought we were on the track, but we realized that this pandemic has shown how gender equality can affect women's health, especially in pandemic. What did you see? We have seen that the sexual and reproductive rights of women were at stake. We have seen that in the pandemic, there was a silent pandemic of violence against women. And you cannot achieve a perfect health system, you cannot achieve your SDG goals, you cannot achieve a robust healthcare or a future of a country unless you address these issues. So that shows that we need to think about a holistic approach to women's health. Being a gynecologist, yes, my focus is on women's health and how it contributes to the overall health of the society. We were dealing with issues of the sexual and reproductive right. We saw in the COVID pandemic, the contraception and other essential services which we offer to our women were affected. The screening services were affected. So, what did it lead to? Suddenly, we realized that there was a chance of our increasing the maternal morbidity and mortality because of these emergency services which couldn't be rendered to our women. So, friends, we at that time actually got together as a global organization, and at India, we decided that unless we actually address these issues, yes, there were so many issues which affected, as rightly put, yes, by Dr. Bhaskar Rao sir, that when you're looking at the healthcare system, you look at the facilities, but you have to see what is it which is required for the health of the woman also is taken care of. Now, we are looking at trying to have a cancer cervix mukt Bharat. That is the goal of the government of India, goal of Foxians, goal of FIGO. But we have realized that all the factors which would help us, like, for example, the screening, the vaccination, all these were affected when we were hit by the pandemic. But at the same time, we realize that these are so very important that unless we address these issues, we will not be able to make a difference. Now, we have seen how vaccination, when made available, how successful it can be. And that has actually made us to take forward the message of HPV vaccination. If we can actually vaccinate 90% of our girls, then if we screen all the women and those who tested positive, if we can even give them 70% of them the best of the services, vaccination, and 90% to treat them, I'm sure that we will be on the right track of cervical cancer Mukt Bharat. We have the government of India, we had the Prime Minister Beti Bachao, Beti Padhao initiative, which is aiming at equal opportunity and education for girls in India. Why is it that we talk about Beti Bachao and Beti Padhao? Foxy also, we said, Save the Girl Child, which was an initiative, because this girl child is the one who's going to grow up to the woman. And a healthy girl will definitely lead to a healthier woman. And she's a future. There's so many interventions which are there, which have been actually for the adolescent girls, for young women. So all these are actually working to make forward and very resilient healthcare system. See, we have been looking at maternal mortality and morbidity. We were in very bad shape of a decade back, more about 15 years back, and slowly we realized that collective effort by the government, private sector, Foxy, and all the stakeholders, be it the OB-GYNs, be it the partners, the WHO, the UNICEF, the JAPIGO, so many partners, USAID, everyone get together. And if we go into the skill and drill training, we go into the emergency obstetric training, we can definitely come out with better healthcare. And we have realized that we have been able to reduce the maternal mortality. In fact, Telangana is doing extremely well. Telangana and AP have actually reached very good maternal mortality rates. It's less than 60. Right now, the NHFS data has shown that we are doing very well. But in the beginning of the pandemic, there was a situation where that probably if you don't take care of these issues, there is a possibility that you lag back, that you may miss the targets which you have achieved the past few years. So we have to actually keep ourselves very well informed, involve all the stakeholders, and see that we don't lose any opportunity to address these issues, so that we don't get back on meeting those targets, we don't get back on missing those indicators which actually look at empowering women for a better health system. Now, when you look at contraception and family planning, these are the core components of essential health services, and access to these services is a fundamental human right. Contraception must be available to people wherever they want it and whenever they want it. About 30 years back, my professor used to tell me it's a national emergency. You cannot refuse this service to any woman. And we have realized that in the pandemic, that this is so very important. So come what may, these essential services should not be compromised. And whatever you're looking, you're having the ICUs, we have the other care facility, the pulmonology units, and all. Simultaneously, we know that we have to invest on the obstetric ICUs, the critical care units, because the pregnant women were more vulnerable to the effects of the infection, and it's two lives which we are dealing with. If we don't have access to the OICUs, and we would be at a disadvantage. That's so very important that we take care of our women. And not only that, we have also seen that the violence against women is a very, very, I think it is a pandemic which has taken greater role in this COVID pandemic. And that definitely affects the health and the well-being of the woman. And we have seen that only unless we address this issue, unless we all say no to violence against women, we will not be able to make a difference. In fact, as the Foxy president and being the FIGO, I had initiated Dhira, no to violence against women, to show the commitment of the OB-GYNs, because we are the first point of contact for women who have any issues with the violence, domestic violence, or any other intimate partner violence. And we are looking at advocacy. We are trying to bring together the police, the legal people, the patients, the public, the male partners, to come together on one platform so that we can address this. So unless you address this violence against women, we will not be able to make a change. Gender equality and violence against women are so closely interrelated, and they affect the health of the woman and, of course, the family at large. In fact, this year we have started this Dhira online school certification course, which I've initiated with the UNICEF India. Catch them young, from the 9th to 12th standards. We are having a 2 hours online certification course where we address them and tell them what voice and how it affects the health of the women. And unless we address this issue, we will not be able to make a difference. Friends, when you're looking at a healthcare system, you do understand that you have to address all the issues to achieve holistic health. I'm sure Professor Amitabh Banerjee will be giving us an epidemiological outlook of how the pandemic has affected the overall health of the society. But I can't help but talk about women's health because that is our forte. So thank you very much.
Thank you very much, ma'am. You have touched upon a very important aspect, that is the importance that needs to be given to women. And we are glad a visionary leader like you are heading an organization like Foxy. You're the president, and you're also working with the government towards this SDG, Sustainable Development Goals. We are happy to have you. And ma'am, would you like to briefly tell us about your initiative called Dhira?
Yeah. Yes, Mr. Sudhir, Dhira is an initiative which Dhira means courage. This initiative actually I started in 2016 when I became a member of No to Violence Against Women of FIGO. That time in 2015, we knew that there was something, the violence against women is not something new, and it is there across the globe. And when I became a member, then I realized that there is something which we have to do. So what is it as OB-GYN we need to do? So that was the time when I realized that we are the first point of contact. So we need to create the advocacy. I need to generate that sort of concern among my OB-GYNs. So that's how we created this more to an advocacy, to actually make our own obstetrician aware of this issue, so that when the woman comes, she may be coming with any problem, but see what is behind that. She may come with a recurrent pain abdomen, she may come with menorrhagia, but look what is it is there behind those physical problems. And you find that sometimes it's that violence. And then because the patient will go to her obstetrician as a first point, she wouldn't go to the police station or to a lawyer first. So if we don't give her that sort of emotional, sustainable support, where else she will turn to? So this was the thing. We did cyclothons, we did bikeathons, awareness, public awareness programs. We in fact invited some celebrities to join, because media coverage is there only when celebrity is there, and we have to send out the message to the public. So we did over a series of years these programs, and we have been able to bring most of the stakeholders, the SHE teams, the police, and everyone on one platform. And I'm very happy to tell you that I've been able to take this across globally also, to the FLASOC countries and to the FIGO. And let me tell you, we women in India are much more empowered than in many other places globally. We have an MTP Act law, which is actually supporting a woman's sexual and reproductive right way back in 1970s. And still now, unfortunately, in the so-called developed countries like US, Europe, and some countries, they still have some places where abortion is criminalized, where all sorts of discriminatory laws are in place. And now in 2021, our government has amended the MTP Act also. So that is going to make the women's health a priority. And when we took this, when I took this Dhira to the FIGO Congress, there, the South American people were said, no, you can't do it. It's a very political issue. How are we going to address? Then I had to put my foot down and say, FIGO was supporting me. That time I was not the trustee. I was just a member. I said, but the president and CEO were with me and said, this is our Congress. We are the global voice of women's health. Whether you like it or not, we are going to do it. And that day I realized globally, all the societies of FIGO, the OB-GYN societies joined that. And there I realized that all statistics right. Globally, across the country, 35 to 45% incidence of domestic violence and violence against women is there. Actually, when you look at it that way, we in India are actually, in some places, many of us are very empowered, and we actually should take it on ourselves to see that we empower the other women whom we serve. And that is not possible unless we partner with men, unless everyone feels that, yes. And the terminology should be changed. Why is it we're calling violence against women? Maybe we should say it's violence by the men, because who is it who is doing the violence? So right from the terminology, there is a gender disparity. I'm not a feminist. I don't believe in just making a noise, but I believe in making every human being responsible for gender equality, everyone in the society, for a holistic growth of the country. Thank you.
Thank you very much, ma'am, for taking that initiative. And we are glad an empathetic leader is on the forefront, raising the voice and also trying to connect and bring a difference. We are happy and we are glad to hear you about that, and we wish you more and more success on this front. With this,
Can I just add one point? We have
yes, ma'am.
started this online school certification program. We have trained about 800 master trainers, our OB-GYNs teachers. My aim target is to reach 1,500 schools this year. And by the end of the project, I am hoping that the Education Ministry will make this DIRA online school certification course a mandatory course in the curriculum from the 9th to 12th class. That should be the aim. That will bring about a change in the mindset of the next generation.
Absolutely, ma'am. We IndiGlobal Media Network closely work with various state governments and also Government of India, and we are there in that initiative with you. We'll work hand in hand. We'll try to do our best to what Foxy is doing. That's an amazing initiative. Thank you very much, ma'am. With this, before we request our next healthcare leader, Dr. Amitabh Banerjee, to deliver his address, we would, as a token of appreciation to our speakers, including, we would like to hand over speakers a token of gratitude and appreciation to our speakers. We would like to present the speaker's certificate to Dr. B. Bhaskar Rao, Managing Director, Kim's Hospital, for the wonderful time and the valuable inputs that's been given by him. He's a leader who has given the holistic approach and the perspective. Thank you very much, sir. And we would also like to present the speaker certificate as a token of gratitude and appreciation to Dr. Shanda Kumari, President of Federation of Obstetric and Gynecological Societies of India. Thank you very much, sir and ma'am. With this, we would request our next speaker, Dr. Amitabh Banerjee, Managing Director, Epidemiologist, Dr. D.Y. Patil, Medical College, Pune, Maharashtra. Sir, over to you.
Thank you, Gautam, and I thank IndiGlobal for giving me opportunity on this platform to share my views. As an epidemiologist, I can just count. I don't have much of deep into any subject, but as an epidemiologist, we see the big picture, bird's eye view. And what I was observing for 2 years, I was collecting the data from the global pattern, and some very interesting thing came out. Earlier, we used to teach infectious disease and non-infectious disease. The theme of my talk is control strategy for infectious and non-infectious disease. Earlier, we used to have separate risk factors for infectious disease, separate risk factors for non-communicable diseases. And a very interesting, fascinating pattern was observed, and I will be just sharing some tables with you, which showed that this boundary is artificial. Both are very closely interrelated. the infectious disease, high incidence of infectious disease can be due to the high incidence of non-communicable disease or non-infectious disease. And what I was teaching my students the risk factors for non-infectious disease. Now I teach them this risk factors are for all diseases, whether it is non-infectious or infectious. The pandemic has brought out the close relation between non-infectious, that means the overall health, and the infectious disease. I say that non-infectious disease risk factors for non-infectious disease will kill you in 20 years, whereas those same risk factors can kill you in a week by acute communicable disease like any respiratory virus. We had a pandemic of coronaviruses, but it can be any. So I would be trying to present some very fascinating data, what we saw, and you have also been observed, and all my data are collated from the public domain. I tell my students to make these tables and the same patterns come out. In fact, we had tabulated for almost 180 countries and the same pattern came out. What we did was we hemisphere wise, the Caucasians, the northern hemisphere, the Asian countries and the African countries, we tabulated the deaths per million population just as a comparative impact. To know the comparative impact of the pandemic on different continents, we tabulated the deaths per million. We did not take the cases because cases depend on the testing policies, but deaths are the hard data. So lessons what we learned was that this pattern, the deaths per million, were related with obesity and age. So age is well known, but obesity pattern came out very sharply. And of course, over the year, that these are the things which we will be seeing in the subsequent data, that obesity is also per se is a high risk factor for the respiratory morbidity and mortality from respiratory infections like coronaviruses or even by influenza, because obesity impairs your lung function. And secondly, obesity can be a surrogate marker at the population level for obesity, increase the risk factor for diabetes, hypertension and other non-communicable diseases. So control of obesity was very strongly related to the death rate. Can I have the first slide, next slide? So this is, next slide please, Gautam. Anyway, these are well-known factors that hypertension, diabetes, when we went into more depth, of course, these were the comorbidities which are now well identified over the past 20 months of the pandemic. Next slide, the comparative tables I am showing. Next slide, please. This is this previous one. The first step, this is the one. Here actually I have taken some countries from each continent, from the northern hemisphere, from Asian continent and African continent, just to show you a quick comparison on one slide. As I said, we have done for many. The first tabulation we did in the start of the pandemic, that is in somewhere in May 2020, when the pandemic was declared in March, a few months into pandemic. These are the deaths. First column is the deaths per million. So if you see the northern hemisphere, USA and European countries, the death per million were in 3 digits, except for Brazil, which the pandemic started late there. Whereas the Asian countries were single digit deaths per million, and the African countries were in decimal places, except for South Africa, which was 2. And the same deaths per million in February 2022, just about 15 days ago, the data, this is cumulative deaths, are 4 digits in the northern hemisphere, 3 digits in the Asian and 2 digits in the African continent, except for South Africa, which is 4 digits. So South Africa deaths are almost like European. So what we thought that northern hemisphere has got a elderly population. So age is a big risk factor. So this explains it. But if you see, there are certain outliers. Like Japan has got the highest age. If you see the next column, median age, Japan's age is 48, median age more than the median age of the Western countries, which is around 40. Japan is 48, but Japan ka mortality is just in 3 digits. What is the factor which stands out is the obesity. This is the overweight. This is again from the public domain, WHO data. WHO site is there for overweight. This is BMI above 25. Japan is only 24% are overweight. Whereas most of the Western countries, the 60%, they are 3 times overweight compared to the Asian countries and African countries. And you see, Africa country, other outlier is South Africa, which has got almost 54% overweight, almost touching the 60% of the Western countries, and it has got a 4-digit mortality. Whereas other African countries are having 2 digits. So what we started in the initial stage of pandemic, the 5 to 10 times higher deaths from COVID in the Western countries, and this same gap continues even after many measures, lockdown, vaccination. And the last column is also very interesting, that this was promised, the vaccine comes, the pandemic will be controlled. So this, if you see the vaccination coverage, population level vaccination coverage, you see most of the Western countries are almost 70% vaccination coverage, but the mortality is still higher compared to the Asian and the African countries. African countries have got the lowest vaccination coverage. You see, Nigeria is 2.7% and 3%. And you see in Africa, South Africa has got 30%, 10 times more than the other African countries, but the mortality is still higher. So the vaccine, as we thought it will be a panacea, it will stop the pandemic. These more important are the other risk factors, like most is the driving is the obesity, and obesity increases your diabetes, obesity increases your hypertension. So those are the, in fact, the papers have come subsequently, large data sets, they found that obesity, if you are not obese, you get 70% more protection from COVID death compared to a person who is obese. So if you see 60% of the population of USA are obese in the Western countries, and we are also going towards that. So if you see, if you control your obesity, your protection is 60% or 70%, 70%. And your vaccine protection has come down. It started with 90%, it has come down to 70%, 40%, 30%. After 6 months, there is no protection from vaccine. You have to give again booster. Whereas if you control your obesity, your protection is lifelong, as long as you are non-obese. So if you see, this is the very strong point for having a holistic approach to control infectious as well as non-infectious diseases. If you have a overall health, particularly control of obesity, and this is very important for a developing Brazil. Brazil is a very good example. It is a country like India, which is a fast developing middle class and economy. And Brazil, you see, it has touched the 4-digit, and whereas median age of Brazil is lower than the other Western countries, just 30, around 33. But the obesity of Brazil is almost 60%, 57. Brazil is, is struggling with the death from COVID. Whereas if you see, Japan is having very high age but low obesity. So more than the age, it is the obesity which is driving the pandemic. And a very interesting thing about Japan, Japan has got a very high vaccine coverage, though it has still got a lower 3-digit mortality compared to the West. Vaccine coverage is 79%, but if you see the Japan trend, if you go to the worldometer and just click on Japan, the Japan had much lower mortality than even this before the vaccine rollout in April 2022. After the vaccine rollout, there is a spike, and Japan did not have mandatory vaccination. Japan had totally voluntary, but when there are policy, when it is not forcing vaccine by direct or indirect means, it has got a very high vaccine uptake because the people trusted the vaccine. But after the vaccine rollout, it is in the public domain. If you see the rollout of vaccine, the cases spiked and the deaths have also spiked compared to the earlier Japan. Why I am stressing on Japan, the same phenomena has happened in other countries, but why I am stressing on Japan is Japan did not have lockdown either. Japan and Sweden are 2 countries which did not have lockdown. And one can say that other countries also where there was spike is very evident after the vaccine rollout is Malaysia, is Sri Lanka, if you go to the data. But people will say that it was because after vaccination the restrictions were lifted, therefore spike. But Japan did not have. Then there is a spike in Israel also, which is on the 4th dose. Then there is spike in Singapore also. So this that we have to think whether, because we are spending a lot of money on vaccination, 35,000 crores India has given for 70 crore, 150 crore doses, 35,000. And if the vaccine doesn't work after 6 months, what happens? I mean, again, we give the vaccine. It is public health policy has to factor in the cost factor also. So these are some countries I have taken. Then subsequent slide, next slide, I have taken other continent. This is the northern hemisphere. You see, the same pattern continues. Sweden, Sweden did not have a lockdown. And it was, if you see today, in the Western country, it did not fare very badly. It is in 4 digits. Second last row is Sweden, but it is much less than the countries which had very restrictive measures. Because this type of data is important because we should know which worked, which did not work. So obviously, if you see the Japan data and the Sweden data, it is the continent which matters. And Sweden has a high obesity like all Western countries, 56. So most of it can be explained by obesity. But still, it did not have a lockdown. It did not have a mass mandate. And of course, it has a vaccine coverage similar to other years. And its rates are much lower than the other Western countries. Belarus also did not have a lockdown. So its rates are also low. Next slide, please. Some Asian countries I will be showing. Next. If you see some Asian countries, if you see our neighbor Pakistan, it has got 1/3 of the death from COVID compared to India, and its vaccination coverage is 43% compared to India's 56%. So there have been a paper also subsequently. They have done the 68 countries and almost 2,947 American counties. They plotted the vaccination coverage with the trends and deaths from COVID. They did not find any strong correlation between the vaccination coverage and the decreasing trend. So that puts a question to a policy whether whether tackling the disease piecemeal is more cost effective than tackling the overall health. Because overall health, where the mortality, the data tables are showing that the mortality is more associated with obesity levels, which is a surrogate marker for other comorbidities rather than just vaccination. So it is very difficult. Piecemeal solutions are very costly and it does not have much impact on that disease also which it is trying to prevent. Similarly, Sri Lanka had very low. If you see 0.3 earlier in May 2020 and now it has gone higher than India. And the vaccination coverage is higher than India and it is double than India. And if you see Bangladesh's vaccination coverage is just 37% and its death rate per million is 173. So if you see, and similarly Japan, of course, I have already explained. Next slide, please. We'll come to some African countries. Next slide. So African country, as I said, South Africa has got the highest vaccination coverage, 30, but it has got the highest mortality also. And other African countries, if you see, Egypt has got almost second highest vaccination of 29. It has got the second highest death also per million. Of course, Egypt where obesity is again 60%. So higher obesity, but it has not gone as much as South Africa, but compared to other African countries, obesity is just 20% like other Asian countries. So where obesity is less, you see the death rates are also less. And obesity has got a stronger correlation with the deaths per million than the vaccination coverage. Next slide. This will be summing up the take-home messages. Throughout the pandemic, we have seen the Western countries had 5 to 10 times higher mortality compared to African and Asian countries, with few outliers, which proves the point. Outlier are South Africa, obesity. Outlier is Brazil, again obesity. Outlier is Japan, leanness. Age and more importantly, obesity as measured by EMF are strong predictors of this difference, irrespective of vaccination coverage. Japan, Brazil, and South Africa, outliers in each continent, further establish this point. In spite of higher and lower obesity acted as protective in Japan, opposite was the case in Brazil. Obesity per se reduces lung function and also surrogate marker of other comorbidities like diabetes, hypertension, and heart disease. And this is a very important thing for Indians, because Indians and Asians, they get diabetes, they get heart disease a decade or two earlier than the Caucasians because of a genetic makeup. We are more vulnerable. We get diabetes in the 30s, 40s, 50s, heart disease 30s, 40s, 50s, whereas the Caucasians get it in the 70s and 60s. So we have to be very careful, and unfortunately what happens, a younger person gets diabetes, younger patient hypertension, initial stages, these are asymptomatic. Person does not feel any symptoms and they are missed. 50% of our diabetics, young diabetics are not aware of the diabetic status. 50% of our hypertensives are, we did in our field practice area, we have carried out, we have published studies, I will be giving the references, that diabetes, 50% young diabetes were not aware. Then we have done studies to find out the increasing risk factors for non-communicable disease even among our rural population. We have published those studies. So we are gradually going the Western way with the economic development. So all this obesity and all this non-communicable disease related to lifestyle factors like physical activity, diet, tobacco and alcohol, as Dr. Rao had already very well brought out. Stress, and studies can explain 50 to 70% of excess deaths. They have done studies can explain these other things. Next slide, please. So, and now let us see, like I said, public health, you have to not see only at one disease, which is each country has got its burden. So if you see COVID-19, everybody is focusing on that. We have got a lot of lessons to learn from COVID-19, which can be applied for other disease control. But it is time that our obsessions with COVID-19 should be stopped. So, but the lessons learned from COVID-19 should be applied to other diseases. The mortality, this is a meta-analysis of many countries, including India. 0 to 19 years, the mortality survival is 99.9973. Matlab, a child gets COVID up to 19 years, his survival, whereas infant mortality rate in our country is 3%. Without any disease, an infant, 3% of our infants die before they reach their first year. 2,000 children die every day. So, COVID, whether we really require to focus on children, it is a debatable point. And right up to 69 years, up to 60 to 69 years, the survival after COVID infection, including the subclinical infection from serosurveys and all, 99.41%. I am 68 years old, my survival, I get COVID, my mortality is 0.5%. And overall, a young girl, 40 to 49 years, the mortality will be 0.05%. Up to childbearing age, Dr. Shanda Kumari gave some data on maternal mortality. Maternal mortality in India is almost 0.1%, whereas mortality of a woman from COVID is 0.05%. So normal pregnancy has got higher mortality than COVID in that age bracket. So we have to think, we are thinking of vaccine for pregnant women, vaccine for children, without any disease. More, 3% of our infants are dying, 3% of our under 5 are dying. Without any disease, almost 0.1% of our pregnant women are dying. So when you are thinking of this, you have to think in a big fashion, and we are in a big picture. We have to see the big picture of this simple data. Then I will be, next slide please. Next slide, I will be showing some other, we have got other unresolved burden. Typhoid, we have got almost 3% mortality even treated cases. Here, untreated cases, we have got survival of 99.9 in young people up to 60 years. Here with treatment, typhoid is 3%. Dengue, untreated can go up to 10 to 20% mortality if the person goes into hemorrhage. And young people die of dengue. Children are bitten by mosquitoes when the schools are open. We don't close schools for dengue. You can't, so it is just as common sense. You see, Japanese encephalitis every year we are having in the Uttar Pradesh, certain states, and the mortality, it affects children. Mortality can be 30 to 40%. For that, vaccine is required, and we should stress on those. Seborrheic scab, tuberculosis, daily 1,400 people die of tuberculosis in our country. We have got a vaccine for tuberculosis. We have got BCG vaccine. It is as good as a COVID vaccine, because BCG vaccine also claims that it prevents severe disease and death. So, okay, give BCG vaccine then every 3 months, every 6 months. Give BCG vaccine to the grandfather, grandmother, so that they don't transmit to the children. You are not doing that for BCG vaccine, which is a vaccine of more than 50 years, 60 years. We are not doing that. Why we are going for this vaccine, which is hardly 1 year and which is not posing a danger to children, whereas tuberculosis is posing a danger to children. We have got a BCG vaccine. So what I am saying is, we have to have a perspective. Western countries may do it because they don't have TB, they don't have typhoid, they don't have dengue, they don't have Japanese fever. They can go after this one. For them, they are obsessed with it. So we have to have our own public health policy, depending on the epidemiology. Child deaths, every day, 2,000 children die in India against a background of malnutrition. They die of diarrhea, they die of respiratory infections other than COVID. Hardly one child dies of COVID. Few months back in December, the statement by NTI member was, there was not a single death of COVID below 12 years in the 2 years of the pandemic. Not a single death. But every day we are losing 2,000 children due to preventable diseases. And we have caused this lockdown, economic year. We have closed schools. Children used to get midday meal. The UNICEF projected that this 2,000 will turn into 4,000 because of poverty and more malnutrition. So this is a disease burden. So we have to think of all the diseases, and what I was saying, lessons learned from COVID. We do not have a monitoring and surveillance system for these other communicable diseases which are bigger burden. So what we had developed in COVID, I suppose we had a session on digital platform also, telemedicine, digital, all that same way, like we were monitoring daily the COVID cases and deaths. Why we don't have it for a real disease like typhoid, dengue, Japanese fever, tuberculosis, child deaths? We should develop that same platform and comparative with whatever, maybe COVID, tomorrow there may be another pandemic. We should not lose a perspective. We keep all the diseases and accordingly prioritize where the money goes, public health allocation. Firstly, we have to increase the health budget and it should be in the right place. Next slide. So these are, again, this is why gradually we are going the American way, particularly the modern Indian, the middle class. We are such a big country. We are a country of 140 crores. UK is 6 crores, Sweden is 1 crore. So 140 crores, we have got all countries in India. We have got an India inside India, we have got an America inside India, we have got an Africa inside India. Everything we have got under India. 6 crore hum nikal denge alag se population. And they must have faced the same mortality as the Western. Those second wave may affected the middle class. They are the sedentary class. Therefore, there was a big stampede and there was a high panic and because there was the middle class who were more vulnerable, because they had gone gradually, their lifestyle had gone towards the American way of life. No physical activity, sedentariness, alcohol, tobacco. So earlier days we were having the cycles. Most of us used to go and there we had a physical activity, open air. Open air where there is no transmission. And vitamin D, studies have come out that vitamin D deficiency makes you more vulnerable to COVID, morbidity and mortality. Vitamin D deficiency even affects your response to the vaccine. If you have vitamin D deficiency, your vaccine response, antibody response is also poor. So vitamin D, everybody is vitamin. We had done studies in our field practice area. We found the younger generation 4 times more vitamin D deficient compared to the, I will give the reference. Now we are going in the car. My students come in car. When I was their age, I hardly entered a car. So they are not having vitamin D, they are not having mobility, and they are in closed space. Next slide. Similarly, the workplaces. Now we are having air condition there. Earlier verandas and all, there was ventilation, sunlight. There was no chance of respiratory infection. Next. Now we are having cubicles, so which entraps the air. So there is no ventilation. Next. This is the Japanese diet. I have never eaten Japanese diet, but I saw the tables that Japanese are the most healthy and long. So I took from the net that Japanese eat this, but I don't know. But it looks quite healthy. It looks more or less like our Indian diet. There is a bhat hai, sabji hai, and fruits are there. And our Indian diets also, all Asian diets, Japanese, Indians are so much variety. I've got Maharashtra, I've got South Indian diets are so healthy. All variety of and now we are the middle class and particularly the class which is working from home and sedentary, they are going towards the American diet. Next slide. This is we are going there. So this involvement not only of doctors, of people, of schools, of education systems, school canteen and all to promote the healthy diet. Next. So this is, they have done studies in USA over the 2 years, average person gained 5 kg. Many people gain 20 kgs. Even children gain 20 kgs. So they have become more vulnerable to obesity. So changes over the pandemic only. And over the years also we are going that way. Next slide. So what are the research shows? That, as I said, study in our institution found that young generation 4 times more likely to have vitamin D deficiency. Comorbidities like diabetes, this is also our study, also increasing in villages. Most were unaware of their diabetes status. Risk factors for diabetes were found among younger age group both in urban and rural areas because they are drinking thumbs up, coke and other things. And studies, this is another study which reported no association COVID-19 with population level vaccination coverage. As I said, 68 countries, they have collected the data and more than 2,900 American counties. Next slide. So this is based on this is a summing up. What should be your strategies? Prevention of both communicable as well as non-communicable disease. One is the primordial prevention. Up till now, I could only theoretically teach my students primordial prevention. I hardly understood, the students never understood. Now I understand what is primordial prevention. They say the primordial prevention is that you prevent certain lifestyles which are found to be unhealthy in other continents. Like USA, we have got unhealthy lifestyles, unhealthy food, lack of exercise, sedentary, tobacco, alcohol, to come to those places where already those lifestyle have not taken roots. That is primordial prevention. Here we have got a chain of McDonald's, we have got a chain of soft drinks, we have got cricketers. So that is the market forces. Now, as I said, in our area, we found the rural area also. They are also penetration. So it may be very late for primary prevention. But like Asian countries and African some communities, we have found low obesity rates, healthy food. So that is primordial prevention. Prevent adoption of unhealthy lifestyle. But we can still do it. At least the children in schools, from primary school, middle school, they are very receptive. Data can be shown to them. They are very bright nowadays. They can see the net. I tell my students to tabulate it. And they say that obesity doesn't kill you only from cardiac disease and nothing. It will kill you from communicable disease. Maybe the next pandemic, any pandemic. So it is a. Then second is health promotion. Health promotion is control of obesity, control of vitamin D deficiency, and healthy diet, sleep, exercise, and freedom from anxiety. This will prevent, promotion means it will prevent you not only against one disease, but against a wide range of diseases. That is health promotion, good health. And specific protection is one particular thing for one disease, that is vaccines. That is piecemeal prevention. And that may work, may not work. Then how much vaccine is affected, the tables are very humbling. It is disappointing rather. It is like when you are young, you think if you get a young couple in love, they think कि अगर प्यार हमको beloved मिल गया तो हमको happiness is complete. That is necessary for my happiness and sufficient for my happiness. After your honeymoon period is over, you know यार necessary तो है पर sufficient नहीं, हमको EMI भरना है, हमको पैसा चाहिए, खाली necessary to sufficient नहीं है. तो सिमिलरली हम जब नया नया वैक्सीन आया, नया टेक्नोलॉजी, हमने सोचा बस यार ये वैक्सीन मिल जाएगा, पैंडेमिक खत्म हो जाएगा. The big CDC and WHO were behaving like a young couple. The vaccine will solve all problem. Now they realize यार वैक्सीन तो आ गया है, necessary होगा, elderly morbidity वगैरह prevent करता है. But ये sufficient नहीं है, इसके बाद भी pandemic चल रहा है. After 10-20 years of marriage, I have got 40 years of marriage. यार neither for my happiness, neither you are necessary, neither you are sufficient. I can be happy by talking to you and talking on IndiGlobal. My happiness is, but still you are by something. वो संजय कुमार का गाना था ना आंधी में, तेरे बिना जिंदगी से कोई सिकवा नहीं, पर तेरे बिना जिंदगी भी जिंदगी नहीं. So without my loved one, I am happy. But यार वो चीज नहीं है. I still require a company. So vaccine can be like that. It has gone through the stages. Initially, like a new couple, we wanted registration. जल्दी से शादी कर लो तो जल्दी से emergency use authorization कर लो. अभी यार इससे तो रुक नहीं रहा है. पर फिर भी कुछ तो है. चलो selective. So this has specific protection has gone through the stages. You should not fall in love with only one person. I mean, I'm not saying that type of love, but you should not depend your happiness only on one person, and you should not depend your disease control on one vaccine. You should have a big, that you should develop yourself. The couple doesn't grow if they are just engrossed in each other. After some time, the fight starts and divorces are common. So if they have other interests, enrichment, and then they come back together from time to time, that is the way to live. Whether it is a public health policy or personal policy. Then secondary prevention. Secondary prevention is early diagnosis and treatment. So in this, I would say screening for comorbidities like diabetes and hypertension, and the national policy should have this as a, because we don't have, you go to the primary health center, simple anti-diabetic drugs are not available. So, and that we are not preventing diabetes. We may be preventing diabetes. We are preventing also communicable disease, future pandemic, because we have seen in this pandemic that those who are diabetic have got higher mortality from a communicable disease, any virus. It may be COVID virus, it may be other virus also. If you see this malnutrition in children, they kill a measles, kills malnourished child 200 times more than a well-nourished child. In well-nourished child, measles, even without vaccination, they did earlier data was there, hardly had any impact. So similarly, a coronavirus in a diabetic or a hypertensive other is 10 times more lethal than a person who has diabetes under control, obesity is under control. Tertiary prevention is debatable. Long COVID, that is again an abstract thing. Nobody knows what is long COVID. Well, everybody has COVID in our country, either clinical or subclinical. अभी कुछ भी होगा, मेरे को हेडेक भी होगा, मैं बोलूँगा यार वो कोविड के लिए हुआ होगा, कुछ भी होगा उसके. So this is something which we have to, more than that, tertiary prevention is long-term prevention. After every event is over, we require a very strong tertiary prevention now for psychological, social, educational setbacks due to this lockdown and other restrictive measures. Because they say that 2 years in a child's life, a 5-year-old child, 2 साल स्कूल बंद है, मास्क पहना है, उसका लैंग्वेज स्किल्स नहीं डेवलप हुआ, उसका सोशल स्किल्स नहीं डेवलप हुआ. That time, first 5 years of life, 90% brain development takes place. So we have to personally think we require psychologists, educationists, social workers to follow up these children. What is the impact on them? And as I said, lastly, monitoring and surveillance of both infectious and non-infectious disease using experience of COVID-19 monitoring. We have to have comparative data. जैसे आप गवर्नमेंट में 3 टेंडर आते हैं, कहीं एक कोई ठेकेदार को आप नहीं देते हो, उसका you ask for different vendors. Similarly, we are a country with multiple and neglected diseases. So वो सबका टेंडर हमको साथ साथ दो, उसी से हमको पॉलिसी बनाना चाहिए. What we are doing now is tunnel vision. Epidemiology means it's like a chessboard. You don't see only on one piece. You have to see the whole board. So this is my. I am ready. Next slide, please. Next slide will be some references. So this is, as I said, we did a study. We have published it. Vitamin D was 4 times less. Then this is on a second on diabetes. We found 50% diabetics are not aware. Then risk factors for non-communicable. And last is that there is a published study in European Journal of Epidemiology, 68 countries and 2947 countries in the United States, where did not find that, as we know now, there are data which is available in the worldometer, that after rollout also, it is the immunity lasting 3 months, 4 months, 6 months, so spike is there. I think that's all. Thank you. We can take any questions.
Thank you very much, sir. That was quite a rich presentation and we thoroughly enjoyed it. And thank you very much. It gives a overall lifestyle changes that we need to make. And I hope the government, we would also be presenting our conference report to the governments, various state governments, especially who are the policy makers. I hope this reaches to them and it will also help them come up with certain policy interventions. Anything from you, Kanisa?
Yeah, it was very good, sir, Professor Banerjee, and thank you, Dr. Shanta Kumari also. Banerjee, sir, I would just like to know from you, the epidemiologists need to be heard in this country. So what is to be done? And they also need to be strengthened at the state levels, because since health is a state subject, whatever the epidemiologist is telling the state governments, they have to at least adhere to them. What we found before the pandemic, during the swine flu time, whenever the epidemiologist would project that these sections or these districts will have high cases, they were not taken that seriously. So what should the epidemiologists do? ICMR also has an epidemiology wing, and how must they strengthen themselves so that they are a voice which the government listens to?
Epidemiologists cannot work in isolation. And I am happy that at least you are hearing me and how much reach you have got, that is enough. I mean, you don't require too many of epidemiologists like you require clinicians. If one epidemiologist or 2 epidemiologists a state who is good, who has got a perspective, and what is required is even the people can understand the data. We try to project. You see what is happening now. We have got different mutants of epidemiologists. Like they have got different variants of fear. There is one epidemiologist who is doing only mathematical model. He or she is not taking the other inputs which are important. How much is the herd immunity level? How much is natural infection? What is the population demographic? As I showed, if you see the models which were made, even they continue to be made today also. Now they are so-called epidemiologists from IIT Kanpur, who is a computer scientist. He is made that he is going to get the 4th wave. How he has done? He has taken from some countries in the northern hemisphere, some countries, so they had this experience, they had their 4th wave. That I have showed in this data that those countries are consistently having high disease because of their obesity and age. So we have got a different demographic, and I have not covered many things where we are different. We are 10 times more dense countries. We are 20 times more dense population density. Even without lockdown also, with lockdown our density increase. That's why our transmission spread are indoors. So those models will not apply if your inputs are not there. So government is listening to the epidemiologists, but to the wrong epidemiologists, because this mathematics is very fascinating. And these models do not work beyond 2 weeks. And initially also they are deficient models because they have not taken the other characteristics.
Sure, sir. Thank you. Thank you very much, sir.
Thank you.
Thank you.
Thank you very much, sir. It was an amazing presentation and a very rich. We all enjoyed, and we would also be making a individual article on this, and we would be publishing that will reach you soon. With this, as a gratitude towards your valuable time and insights, and also a token of appreciation, we would like to present a certificate on behalf of IndiGlobal Media Network and also our jury members and advisors is proudly being presented to Professor Dr. Amitabh Banerjee, epidemiologist, Dr. D.Y. Patil, Medical College, Pune, uh, Maharashtra.
Thank you. Thank you, sir.
Thank you very much, sir. With this, we come to the end of the opening session of day 2 of the IndiGlobal Healthcare Summit. And we have more interesting panel discussion and leader talks that are lined up throughout the day. So stay tuned. We are live through our IndiGlobal TV in YouTube and also through our IndiGlobal Media Network Facebook page and also in LinkedIn. We are live while many of the delegates have joined us through this broadcast through this 3D virtual platform. With this, I would like to thank all the delegates and participants who joined us. Please connect with us in the next session that would be focusing on healthcare leaders and innovators contributing to the sustainable healthcare systems, emerging healthcare startups, innovation in healthcare delivery. Thank you very much, everyone.